Hi everyone, and welcome to part 1 of 2 of our Pharmacology NCLEX review. Today we're going to be doing an overview of our common pharmacology topics. Specifically for today, we're going to do an intro to pharmacology, and we're going to cover respiratory, cardiac, hematology, endocrine, GI, and our urinary and renal medications. This will help you a lot with not only the pharmacology portion of the exam, but also your med-surg review. So we're going to go ahead and get started. Again, I took my NCLEX in May of 2023, and essentially these are a bunch of notes that I compiled myself while I was studying for my boards. So without further ado, we're going to go ahead and get started with our introduction to pharmacology. So a couple things we want to be aware of. Obviously, we're all familiar with the 6 rights of medications. Be prepared to be able to identify which rights are present and which rights might be missing in a question. Always make sure we've got the right patient, the right drug, right dose, right route, right time, and right documentation. If you're missing any of the 6, you need to be aware of what's missing. Also, it's important to know how our bodies absorb drugs. Oral medications usually take about 2 hours. IM drugs are absorbed within an hour, and IV medications are absorbed in 30 minutes. Also, it's important to be aware of common conversions. Specifically, we've got our degrees Celsius. Essentially, you can take the Fahrenheit minus 32, or you can take the Fahrenheit, the degrees in Fahrenheit, which is what we're more familiar with here in America. And you're going to multiply that by 5/9. It's also important to know that 30 mLs is 1 ounce, 5 milliliters is 1 teaspoon, 15 milliliters is 1 tablespoon. Also important to know our conversions for weight when we're talking about weight-based medications. 1 kilogram is equal to 1,000 grams. 1 kilogram is also equal to 2.2 pounds. And 1 milligram is 1,000 micrograms. These are some of the more common conversions that we will see. Alrighty. I have a little bit of a spiel on kind of when we need to take certain medications. While it's not super detailed for your exam about needing to know specifics on what meds should be taken in the morning, at night, it's more about concepts and overall understandings. What I mean by that is, for example, some of our morning medications that must be taken in the morning, the reason that they're taken in the morning is because they have to be taken alone on an empty stomach with no other medications. So that's why we take them in the morning. Most common is going to be our levothyroxine. These are taken first thing in the morning on an empty stomach. And then pantoprazole, also taken first thing in the morning on an empty stomach, and it has to be, again, separate from other medications. So these are our most common morning medications. And while it's important to know to take them in the morning, it's more important to understand the reasoning as to why we take certain drugs in the morning and why we take certain medications at night. That will help you not have to memorize, oh, my CNS depressants. What are my CNS depressant medications again? Do I need to take them in the morning or at nighttime? Well, it's about kind of the reasoning, the rationale. So nighttime medications, we take meds that can cause any sort of CNS depression, sedation, or dizziness, generally at nighttime. Why do we do that? For safety. We don't want any falls. If it can make them dizzy or drowsy, we can take it at nighttime because they're going to sleep, they're in bed, they're safe. But back to morning medications, our other common morning meds are going to be diuretics. Why diuretics in the morning? Well, they cause polyuria. If you take them at night, the patient's going to be up all night using the restroom. We also give a lot of our cardiac medications in the morning, like our ACE inhibitors. And then SSRIs we take in the morning because a big side effect of those is insomnia. So we already talked about the rationales for nighttime medications. Atorvastatin is also a very, very common medication that is taken at night. It helps lower cholesterol. These patients take them at night. Zolpidem, that's our Ambien, obviously can cause CNS depression and sedation, so we take it at night. We usually take our long-acting insulin at night, and our trazodones, melatonins, things like that, we take at nighttime. So what medications can be taken with food? A lot of the reasoning why we take meds with food is to decrease the risk of GI upset, GI ulceration, So allopurinol can be taken with food. NSAIDs, they strongly recommend you take NSAIDs with food to reduce the risk of GI upset and bleeds. Usually antibiotics are taken on an empty stomach. The only ones we will take with food are the cephalosporins and the sulfonamides. What medication should be taken on an empty stomach? We've talked about levothyroxine, our sucralfate. A lot of our GI drugs, like our pantoprazole, sucralfate, that either alter the absorption of the stomach, reduce acid secretion, coat the stomach. A lot of times we need to take those on an empty stomach as well. And then our bile acid sequestrants. Always remember that whenever you're taking any sort of stomach altering medication, we should not be taking that with other medications because it's going to impair the absorption of other medications. But we'll go into more detail when we talk about GI meds. Alrighty, a couple of the fundamentals of IV therapy, lots of different complications. When an IV infiltrates, it leaks into the tissue. We're going to stop the infusion, remove the IV, cold and elevate, and put a new IV in at a different location. Extravasation is a little bit different. Instead of just like an IV fluid leaking in, a vesicant such as chemotherapy will leak into the tissue, and this can cause damage to the tissues. So we're going to stop, discontinue. We're going to try to aspirate, pull back on some of that medication, see if we can suck it back, and then put some cold. Phlebitis is irritation and swelling. We stop, we remove the IV, and we apply heat. Phlebitis most often occurs when your patient is on like a high concentrated antibiotic, like if you're pushing like ceftriaxone over 3 minutes in like the 20 mLs, it can cause a lot of irritation to the skin and swelling. Hematomas happen when the vein blows, patient gets a really big bruise. We remove the IV and we apply pressure. Catheter emboli can occur if the catheter breaks off. This is an emergency. If this occurs, if it was in the AC, we're going to put a tourniquet up really high on the extremity and then get a stat x-ray for removal. If your patient has a central venous catheter, a big concern is going to be an air emboli. Whenever we're dealing with the central venous cath, whether we have air emboli or whether we're trying to put one in or doing anything with it, the left lateral position helps these patients. When we perform dressing changes, the dressing change must be sterile. With PICC lines, also sterile dressing changes requiring aseptic technique. We're scrubbing the hub for 20 to 30 seconds with alcohol. And big key thing with any of our IV therapies is preventing infection, especially with your central venous caths and your PICC lines, especially if patient's got a PICC line in the upper chest that's going directly into the heart. So we don't want any sort of endocarditis from infections. If your patient is on TPN, this requires strict intake and output, also requires you to check blood sugar every 4 to 6 hours. We perform sterile dressing changes every 2 to 3 days. And when your patient is receiving TPN, we change the tubing every 24 hours. You do a whole tubing change. Little concept about peaks and troughs. What are they? These are what we measure when we have a medication that might have a very narrow therapeutic window or can be toxic really fast, specifically vancomycin. So what is the peak? This is when the drug is at the highest concentration in the body. Our trough is when the drug is at its lowest concentration, okay? We always want to draw our troughs before giving the next dose, because if our trough is really elevated, we want to hold the next dose because we can give them a toxic amount of medications, okay? When do we know when to draw our peaks? If we had a sublingual medication, about 5 to 10 minutes after it's been dissolved. If the patient has an IV, we're going to do 15 to 30 minutes after the infusion is complete. For IM, we check at 30 to 60 minutes after administration. Alrighty. A couple of things to be aware of. We're going to specifically focus more on this when we get to these drugs in the review, especially in part 2 when we talk about psychiatric medications. But be aware of your toxic levels. Also, we need to be aware of drug toxicity and what to do if things become toxic and know our antidotes. So please be familiar with your antidote, specifically knowing that the antidote for a warfarin overdose is vitamin K. For narcotics, it's going to be naloxone, Narcan. Mag sulfate is calcium gluconate. And heparin is protamine sulfate. Benzodiazepines, flumazenil. Okay. And here I just added a little slide for you guys. This is common suffixes, pretty self-explanatory, but it helps you kind of know based on what the medication, how the medication is spelled, can kind of give us a good idea of what the purpose is of the medications. Alrighty. First thing we're going to talk about is our respiratory medications. So first up is our beta-2 agonists, okay? We've got albuterol, salmeterol, and terbutaline. It's just important to know when we give certain medications. Because albuterol is short-acting, it is used for our emergencies. It works very quickly. Salmeterol, on the other hand, again, bronchodilator, but it's long-acting, so it's not good for a rescue inhaler. Same thing with terbutaline. They're not rescues. Okay. How do we use an inhaler? It's important that we remove the cap, we shake the inhaler, then we have the patient exhale before putting their lips on the mouthpiece. Once their lips are on the mouthpiece, they press down to administer, they breathe in and hold their breath. We always encourage patients to rinse their mouth afterwards to reduce any sort of risk of oral thrush. Okay. Up next are methylxanthines. These are caffeine derivatives. So naturally, our sign effects and our symptoms of toxicity very similar to what one might think would happen if someone overdosed on caffeine: tachycardia, tachypnea, and seizures. Okay, this occurs when these levels go over 20. All right, this is going to be our theophylline, the end in the phylines. All righty, up next we have our anticholinergics. First up, we have our ipratropium. This is a fast-acting inhaled medications, but because it's our anticholinergics, you'll hear me talk about this a lot. If we have an anticholinergic medication, they're all going to have the same side effects. We call it our anticholinergic dries. Can't see, can't pee, can't spit, can't poop, essentially. They're going to dry up the body, okay? This can lead to urinary retention, tachycardia, and dried mouth. Okay. Atropine is also a good anticholinergic medication. We see atropine more used for end-of-life care to help reduce respiratory secretions. Up next, we have our inhaled glucocorticoids. Main thing with our inhaled glucocorticoids is that they put the patient at risk for infection and they raise blood sugar because they are steroids. Okay. What do steroids do? They suppress the immune system. It's very important that we must taper when stopping to avoid Cushing syndrome. And while the patient is on this medication, we avoid NSAIDs. Up next, we have our leukotriene modifiers. Most common is montelukast. Just watch the liver function because this can get pretty toxic to the liver. If your patient is having a cough, we can use multiple different medications. A lot of our antussives are cough suppressants. These are our hydrocodone and codeine. However, big side effect is drowsiness. These medications are not safe for patients with COPD. We want to kind of encourage coughing. Guaifenesin, that's an expectorant. Mucolytics, we have acetylcysteine. Decongestion, so we have phenylephrine and mefazoline. Up next, we have our antihistamines. These kind of help more with our allergies. This is going to be diphenhydramine and Benadryl, and sertrazine, which is Zyrtec. Again, these have our anticholinergic effects, so they're going to cause those anticholinergic dries. Be very careful. We should not be giving Benadryl to children as it can overexcite them. And watch your potassium while on this medication as it can cause hypokalemia. Beautiful. All right, my friends, we are going to go ahead and move on to our cardiac medications. Up first, we're going to talk about antihypertensives. Regardless of the specific type of antihypertensives, we have general rules of thumb. So if your patient is on an antihypertensive, we must taper this medication to avoid rebound hypertension. Okay. Also, while your patients are on these drugs, we want to avoid hot tubs and saunas, assess renal function, and our coag panels. So up first, we have our ACEs and our ARBs. ACEs end in pril, ARBs end in sartan. Generally the same, not the same medication, they're different classes, but they're very, very similar. Generally, we place a patient on an ACE inhibitor. These are also what we put our patients on going home with newly diagnosed heart failure. They get sent home on an ACE or an ARB. But generally, we put them on an ACE inhibitor first. However, these can have some pretty annoying side effects. So if the patient's not tolerating the ACE inhibitor, we'll switch them to an ARB. What are our side effects? I always say ACE. We've got angioedema. If someone has angioedema, facial swelling, we give epinephrine. Can have a very annoying dry cough, and hyperkalemia, increased potassium. That's how I remember it personally. ACE, ACE, angioedema, cough, increased potassium. Again, we switch to an ARB if they're having a hard time. For ACE inhibitors, we're going to want to take these before meals and avoid salt substitutes and high potassium foods. ACE inhibitors are good for blood pressure management because they don't necessarily interfere with the heart rate. Up next, we have our calcium channel blockers. These are our very nice drugs, verapamil, nifedipine, and diltiazem. These are good drugs of choice for cardiac dysrhythmias. However, these are not good for patients with heart failure or bradycardia. Remember, avoid grapefruit juice when on a calcium channel blocker. I always say we don't want to mix milk and grapefruit juice with breakfast. It's not fun for the stomach. However, these medications can cause headache and hypotension. Next up, we have our alpha adrenergic blockers. They end in zosyn, like prazosin. It's important we take these medications before bedtime. Up next, we have our alpha-2 agonists. These are our clonidine and methyl-dopa. These can impair coagulation, so avoid anticoagulants and MAOIs. However, these medications we don't see used too often, as they can cause leukopenia. More often in the hospital, clonidine, the brand name is Catapress, we give kind of as needed, not necessarily on the daytime, because they can cause leukopenia. Okay. Up next, we have our beta blockers. They end in olal. It's important to know, is it cardioselective or non-cardioselective? Basically, we have beta receptors on both the heart and the lungs. So if your patient has any sort of respiratory or lung issue like asthma, COPD, we want to make sure we put them on a cardioselective beta blocker. So that's going to be our metoprolol and atenolol. If the patient doesn't have any sort of respiratory issues, we can go ahead and give them a non-selective beta blocker such as propranolol or labetalol. Okay. Always, always, always check your heart rate and blood pressure before giving these medications. Most often for cardiac medications, they will have parameters, hold for heart rate less than 60 or systolic less than 100. Beta blockers can worsen heart failure. That's why our ACEs and our ARBs are the gold standard drug of choice for heart failure. Up next, we have our vasodilators. These are nitroglycerin and hydralazine. Big side effect for both of these: dizziness, headache, and hypotension. Always check blood pressure before giving these two medications because they can drop your blood pressure. Alrighty, up next we have our cardiac glycosides. These help with heart failure. Essentially, they're going to increase the squeeze, help the heart pump more effectively. Most common is digoxin. Remember, with digoxin, we have a very narrow therapeutic window. So always keep in mind, hypokalemia can worsen dig toxicity. If the patient, usually our heart failure patients, we go ahead and we put them on a diuretic to help get fluid off. But if your patient is in digoxin, we want to avoid any drops in our potassium because, again, it can worsen the dig toxicity. So a good drug of choice for these patients would be spironolactone, which is a potassium-sparing diuretic. Okay, remember, digoxin becomes toxic after 2.4. Okay, alrighty. If your patient is experiencing nausea, vomiting, diarrhea, fatigue, blurry vision, or seeing halos, we want to hold the next dose of digoxin, and we want to draw a digoxin level. Up next, we have our anti-anginals. These are used for someone experiencing chest pain. Main side effects are going to be headache, hypotension, and tachycardia. Absolutely contraindicated for patients receiving erectile dysfunction medications or patients with head injuries. Different types of nitro we can give. Most common is the sublingual. Just remember, we put it under the tongue, let it dissolve. We take one every 5 minutes. For chest pain, always check your blood pressure beforehand. The max amount we can give is 3. If it's still unrelieved after 3 doses, you're going to call 911. Okay. The topical is a cream. It's important that we wear gloves when applying this topical cream and we avoid a hairy site. Up next, we have the patch that stays on for 12 to 14 hours, and we just rotate sites every time. Alrighty, these are our most common antidysrhythmic medications. Adenosine is given for SVT. Remember, with adenosine, after pushing, it can cause a brief period of asystole. It's important that after we push adenosine very quickly, we immediately follow up with a 20 ml normal saline flush. That's when you'll see dual stopcock, where you are able to just flush both at the same time. It's very important we flush afterwards with 20 ml normal saline. Okay. Up next, we have amiodarone, drug of choice for AFib with RVR, rapid ventricular rate. Just watch respiratory status on this medication. Atropine is used to treat symptomatic bradycardia. Again, it is an anticholinergic, so we have our anticholinergic dry side effects. If your patient has dry mouth, you can give them like ice chips, sugar-free candy to kind of help with that. Alrighty, up next are our anti-lipidemics. The whole goal is to increase HDL, which is our good cholesterol, our happy cholesterol, and lower LDL, which is our bad cholesterol. Obviously, they must be used with diet and exercise. Big concern is they can cause rhabdomyolysis. So what are we doing? We're assessing the patient for like muscle pain, fatigue, weakness. Most common are our statins we take at night. We avoid grapefruit juice. Ezetimibe is also another common anti-lipidemic drug. However, this can cause liver damage. All right, my friends. Up next, we have our hematology medications. First, going to talk about anticoagulants. If your patient is on anticoagulant therapy, they are at increased risk for bleeds. So we don't want to avoid these medications for a patient who has an active bleed. Okay. Warfarin is very common. Remember, with warfarin, we must check the PT and INR. If your patient is on warfarin, the goal INR is 2 to 3. If it is greater than 3, we want to make sure we give our antidote, vitamin K, because the patient can have bleeds. With that being said, it's important that we avoid high vitamin K foods because that will negate and make warfarin ineffective. However, we don't want patients to abruptly change their diet. If they're used to having high vitamin K foods, that's what the body's naturally used to. So just remember, avoid high vitamin K foods, but we're not abruptly changing the diet. Okay. Up next, we have heparin. Same thing, anticoagulant. For heparin, we want to measure the PTT. Our goal PTT is going to be 46 to 70. If it is elevated, like 200, patient is at big risk for bleeds. So we want to go ahead and give them protamine sulfate. Next up, we have a rivaroxaban. Oh my goodness, rivaroxaban. There we go. It's important with these medications, we keep the drugs in the original container. These meds can cause eye pain. Up next, we have antiplatelets. Essentially, they act as, everyone always calls them blood thinners, but they make the platelets more slippery and they prevent platelet aggregation. So blood is able to slip and slide through narrow spaces. Really good for patients with, coronary artery disease. Big side effect is bleeds. These are not safe for patients with peptic ulcer disease as they can cause bleeding from the ulcers. Up next, we have thrombolytic alteplase. These are given for our patients that might be stroke positive or an ischemic stroke to help go ahead and break up the clot. Must be given within 4 to 6 hours. If the patient had surgery less than 2 weeks ago, it's not safe to give these medications. Or if the patient has any active bleed or wounds, as it's going to cause those clots to dissolve. A little spiel on blood products. It does take 2 nurses to verify the blood product. We want to get a full set of vital signs before, during, and after the administration. Usually we check them before, then we check them 15 minutes after starting, and then after the infusion is complete. These must be given through an 18 or 20 gauge IV. The line must be primed with normal saline only, and you cannot run blood with anything else. We stay with the patient the first 15 minutes to assess for signs and symptoms of a transfusion reaction. This would be abrupt changes in vital signs, wheezing, altered mental status. We must, once we've started the blood transfusion, we must have it finished in less than 4 hours. If we suspect a transfusion reaction, first thing we do is we stop the infusion, we get a full set of vitals, we flush with normal saline, we call the provider, and then get a set of labs. What are some things we might use? Whole blood is given for any sort of trauma or hemorrhage. Packed red blood cells help with anemia. Platelets help with thrombocytopenia. Fresh frozen plasma will help replace clotting factors. Premature granulocytes aren't used as common. They're more used in oncology settings, but they are used for neutropenia. And then albumin helps expand blood volume. All right. Up next, we have hematopoietic growth factors. These help stimulate blood cell production. E alpha will stimulate red blood cell production. Our contraindications will be hypertension and elevated hemoglobin and hematocrit. If hemoglobin and hematocrit are elevated and we give E alpha, it can make the blood very thick and viscous. We've got our filgrastim. This will help stimulate white blood cell production, can cause bone pain, again, more common in the oncology setting. Up next, we have our oprelebkin. This stimulates platelet production. For iron, we can give an IV iron infusion or even an oral iron infusion. It's important that we tell the patients to increase vitamin C in the diet because that actually helps with iron absorption. Okay. Alrighty. Up next, we're going to talk about the endocrine system. Most common is going to be our medications for diabetes and sugar management. First up, we've got our oral hypoglycemics. These are specifically used for type 2 diabetes, again, used in combination with diet and exercise. Alrighty, up first, we have our Archibos miglatol. These help decrease the absorption and digestion of carbs. So are they specifically altering any sort of blood sugar levels? Not necessarily. Essentially, they act more on the food that the patient eats. Up next, we have metformin. We know it's very harsh on the kidneys, so we hold it 48 hours before and after procedures involving contrast dyes. Again, it helps reduce absorption. It's not going to decrease the blood glucose levels. Okay. Up next, we have our glanides. They end in glanide. These help stimulate insulin production by the body, and these should be taken before meals. Up next, we have our sulfonylureas, glucoside, and glyburide. Not safe for patients with heart failure. If a patient has an allergy to a sulfa antibiotic, these are similar, so they will have an allergy to these as well. And I think those are the main ones we're going to just talk about, okay? Up next, we have our insulin. It's important. I know we talked a lot more so in med-surg and fundamentals, but insulin, a big thing. Insulin is going to lower our blood sugar levels. So it's important not only we always check blood sugar before giving these medications, but we're aware of signs and symptoms of hypoglycemia and hyperglycemia. I always say hypoglycemia is cool, clammy, needs candy. Hyperglycemia is our hot, dry, sugar high. When giving insulin, we always have to use an insulin syringe that is measured in units. We're going to rotate injection sites frequently to avoid lipodystrophy. Okay. Be careful, insulin can worsen hypokalemia. Hyperglycemia can decrease potassium. So just kind of be aware that insulin has effects on potassium. And someone, whether they are in diabetic ketoacidosis or have really high sugar or low sugar, we're going to want to make sure that we have the patient hooked up to a telemetry monitor just to take a peek at what's going on and get frequent labs on them. Once we open a vial of insulin, it is good for 30 days. Our rapid-acting insulin, this is our Insulin List Pro. It's important that we give this one with meals because it has a very, very quick onset. Short-acting insulin, this is our regular insulin. Remember, regular insulin is the only insulin that can be given in an IV. This works in 30 minutes to 1 hour. This is our clear when we talk about clear and cloudy, as it can be mixed with regular and intermediate. Regular and intermediate insulin are the only two insulins we can drop in the same syringe and we can mix together. I always remember like Nancy Reagan RN, we inject air into the NPH, we inject air into the regular, then we draw up the regular, then we draw up the NPH. Okay. NPH is our intermediate acting, has an onset after 2 hours. It peaks after 6 hours. Always be aware of when these medications peak because that is the biggest risk for a hypoglycemic event. And then finally, we have our long-acting insulin. This lasts all day and there is no peak. If your patient becomes hypoglycemic, whether it's because of insulin or the patient just has low blood sugar, we can give glucagon. However, glucagon is not necessarily a last resort, but we want to try other less invasive interventions first, such as an oral carbohydrate, but only if the patient is awake and able to safely swallow. All righty. And now we're going to get into our hormonal medications. Up first is our levothyroxine. This is for hypothyroidism. We must take this medication on an empty stomach. Big side effect is going to be thyroid storm. It can cause tachycardia, restlessness, weight loss, fever, and diaphoresis. On the other hand, methimazole is used for hyperthyroidism or thyroid storm. Okay. However, these patients can overdose on this medication. They can have some paraorbital edema, cold intolerance, and depression. Up next, we have somatropin. This is used for patients with growth hormone deficit. Side effect is hyperglycemia, and it is a subcutaneous injection. Up next, we have vasopressin. This is used for patients with diabetes insipidus, which is DI, or hemophilia. It's important to monitor the blood pressure while on this medication, as it can also cause hyponatremia, which puts patient at risk for seizures. A big priority of a patient that is on vasopressin is a headache. If they have a headache, this can be because of the hyponatremia and they are at big risk for seizures. Up next, we have dexamethasone. This is used for patients with Addison's disease or chronic inflammation. Can be used respiratory, can be used for autoimmune. But we see it on the hematology side, more so for Addison's. Okay. It's important we taper this medication. Again, this medication does suppress the immune system. So just keep that in mind. All right, my friends, moving right along to our GI medications. First up, we have our antacids. These neutralize the stomach acid. Therefore, it is important we take these alone and by themselves. Reason being is, again, we talked earlier, if it interferes whether the absorption or the acidity of the stomach, it's going to then impair further drug absorption. So for all these medications, we give an hour in between other medications, and these are not to be used for long-term use. First, we have aluminum hydroxide. Side effect is going to be constipation. On the other side, we have milk of mag. This can cause diarrhea. And then sodium bicarbonate. Side effect is more GI upset and constipation. So these drugs neutralize the stomach acid. Our anti-secretory drugs, they decrease acid production of the stomach. Again, same rules apply, must be given away from other medications and whatnot. Okay, first up is our proton pump inhibitors. They end in prazole. Again, these are not safe for breastfeeding moms, puts the patient at risk for fractures and at risk for C. diff. Up next, we have our H2 blockers. These end in tidine, such as famotidine. Again, a lot of our anti-secretory drugs, big risk for osteoporosis, which puts patient at risk for fractures because they impair our calcium. Okay. Up next, we have protectant drugs. These help coat the stomach, most often used for patients with GERD or peptic ulcer disease. This is going to be our sucralfate. It coats the stomach, okay? I say more so for our GI medications. It's more important to know a few of the side effects, but more so the mechanism of action. What does it actually do? So sucralfate, protective covering on the stomach. Up next, we have our antiemetics. Big side effect for all of our antiemetics are going to be drowsiness and lethargy. This poses a safety concern because if the patient is actively vomiting and we make them drowsy and lethargic, it could lead to aspiration. So just keep that in mind, okay? Up next, we have promethazine. This can cause dry mouth, urinary retention, drowsiness, and extrapyramidal symptoms. We'll talk more about our EPSs in our psychiatric medications. We want to avoid use in pregnancy and for children. Next, we have metoclopramide. It helps promotility agent. Big side effect, again, extrapyramidal symptoms. If these extrapyramidal symptoms like tardive dyskinesia or like our pseudoparkinsonisms occur, we're going to want to discontinue. Ondansetron is a drug of choice for chemotherapy. It generally has very minimal side effects, can put the patient at risk for dysrhythmias and cause headache. Up next, we have scopolamine. These are often given as patches. A lot of times we give the patches for end-of-life care, again, to help with the secretions. Side effects include blurry vision, sedation, dry mouth, and urinary retention. Therefore, we caution in patients with glaucoma. Any of our anticholinergic medications, we generally hold if the patient has glaucoma because we don't want to abruptly drain or dry up that eye. Okay. Alrighty. Up next, we have antidiarrheal drugs. For our antidiarrheal drugs, we really don't want to give these to patients with IBS, as this can lead to toxic megacolon. Up first, we have our loperamide. Again, our side effects are going to be constipation and our anticholinergic dries. Next, we have our diphenoxylate atropine. Remember, atropine is not safe for patients with COPD. So this medication will also not be safe for patients with COPD. Up next, we have stool softeners and laxatives. These medications are not to be used for patients with bowel obstruction, ulcerative colitis, or diverticulitis. Again, we also want to encourage increasing fluids, fibers, and fruits. Psyllium is our only stool softener and laxative that is safe for everyday use. Most of our geriatric population take this every day. This is Metamucil. Up next, we have docusate sodium. It's very important that we take with lots and lots of water. Our Biscadil is our Dulcolax. This works a little bit more quickly than the stool softeners. And lactulose will help, again, help the patient have bowel movements. But specifically, we give lactulose because it helps promote the excretion of ammonia, okay? Alrighty, last but not least for today, we are going to talk about our urinary and renal medications. So, diuretics, they are kind of grouped under urinary and renal medications, but remember, a lot of times we give these for patients with cardiac issues because they are good for patients with heart failure, okay? The whole purpose of diuretics is to promote urinary excretion. So it's important that we ensure we do strict intake and output on these patients and perform daily weighs. We're also assessing for edema and seeing if it's getting better, if it's getting worse, or if it's staying the same. Diuretics can lower the blood pressure, so it's important that we check the blood pressure before giving these medications. Again, these medications are given in the morning because it causes polyuria. So let's talk about the 4 common diuretics. Up first is our loop diuretics. This is furosemide and metadine, most common furosemide, which is Lasix. This will help lower blood pressure. It can also lower potassium. Big issue is ototoxicity. So if patient starts having issues with like their hearing, we want to report that finding to the provider. If the patient starts to begin to experience EKG changes or is having palpitations, we want to hold the medication. Why? These medications can cause hypokalemia. If the patient starts having palpitations or EKG changes, those are indicative of hypokalemia. So if a patient is on this medication, it might be a good idea to have them also on a potassium supplement. Again, that's more so for heart failure. Diuretics also are given to patients that are kind of in a little bit of renal failure because it's going to help get things out as best they can. All right, and more so the earlier stages. Alrighty, up next we have thiazide diuretics, like our hydrochlorothiazide, again, can lower blood pressure and potassium. These are not safe for patients with sulfite allergies. On the other hand, we also have diuretics that are called potassium-sparing diuretics. This is our spironolactone. These will not excrete potassium. Therefore, we want to monitor the patient's potassium level and avoid high potassium foods because they're no longer excreting the potassium, more so for our renal patients as opposed to our cardiac patients. This is the drug of choice for cardiac patients because cardiac patients with heart failure are going to be on an ACE or an ARB. And remember, those medications can cause potassium imbalances. Alrighty. What else do we have? Last but not least, we have our mannitol. This is an osmotic diuretic. This one is a little bit different than the rest of them because this helps with increased intracranial pressure. The other three won't. So if the patient has any sort of brain tumor or any neuro injury or issue going on that can cause swelling, we give the patient mannitol. However, we should be doing frequent respiratory assessments while on this medication as it can cause pulmonary edema. Alrighty, up next we have our alpha adrenergic blockers. These are used for patients with BPH. It's going to help with urinary outflow. We want to avoid use of Viagra or erectile dysfunction medications. Up first, we have our tamsulosin. This should be taken 30 minutes before meals or at bedtime. It can cause some decreased libido, headache, dizziness, and orthostatic hypotension. That's why we're giving it at nighttime. Up next, we have our bethanyl chloride. This is given for patients after having a TURP procedure, transurethral resection of the prostate. It's important we give this medication on an empty stomach. It can cause some bradycardia. All right, my friends. Now we have our anticholinergics. We've talked a little bit about our anticholinergic drugs, but these medications specifically are used for patients with overactive bladder, urinary frequency, or urge incontinence to help dry them up a little bit. Therefore, the side effects are going to be our anticholinergic dries, our dry mouth, constipation, blurry vision, constipation, tachycardia. Not safe for patients with intestinal obstruction or patients with glaucoma. And I've listed them here for you guys. Most often we've got our oxybutynin, pistaridine. These are very common anticholinergics. Alrighty. And last but not least, we have medications for sexual dysfunction. Remember, absolutely contraindicated with the use of nitroglycerin. Okay. These end in nafil. Example would be sildenafil. Again, used to treat erectile dysfunction. We're going to want to avoid the use of antihypertension or antihypertensives. These is not safe for patients with heart failure, stroke, or unstable blood pressure. This medication can cause some hypotension. Patient might experience headache or flushing. They are to take it 1 hour before having sex. If the patient has an erection lasting longer than 4 hours, this is priapism, and this is a medical emergency. So that is all I have for you guys for part 1 of our pharmacology review. Thank you so much for watching along, and I will see you guys in part 2 of our pharmacology review. Happy studying.